friends, welcome back to my channel and to the whiteboard. In today's video, we're going to do a quick review on an atrial septal defect, better known as an ASD. So what I want you to remember when you're reviewing this for your next pediatric nursing exam, or if you're just doing a quick review prior to taking your boards, this falls into the category of a congenital heart defect. So what that means is this is a defect that a baby is born with. Remember, cardiac formation happens very early on in utero. So we know that by the time the baby is born, if they do in fact have an ASD present, it's been there since the formation of the cardiac system. The good news about an ASD, it's very treatable. We now have minimally invasive procedures to repair an ASD. So when we're talking about other heart defects, we know that a lot of those do require open heart surgery. And now in today's day and age, we can actually repair this within the cath lab, which we'll talk about once we get into this defect. So an ASD, or an atrial septal defect, falls also under the category of those disorders that cause increased pulmonary blood flow. That's really important to remember when you're studying defects and you're categorizing them. Think about some of the effects that we're going to see in the signs and symptoms. It goes back to the fact that it's causing this increased blood flow to the pulmonary system or the pulmonary artery, which I'll show you in a second when we kind of get into my drawing here. This is also an acyanotic disorder. So if it's acyanotic, we're not going to see cyanosis, throughout systemic circulation. So I will also explain to you why, in fact, it's acyanotic. So when you're studying an ASD, remember the A, atrial, it's an acyanotic defect and it causes increased pulmonary blood flow. So let's get into what this defect actually is. So when we're talking about an ASD, in very simple terms, it's that opening between the right atria and the left atria within the septal wall. Remember, you have 4 chambers in the heart, 2 upper, 2 lower. We're focused on the 2 upper chambers looking at the right atria. So again, we know that that hole in the septum would have happened very early on in utero with the formation of the cardiovascular system. Signs and symptoms. The cool thing, or not so cool, I guess, because it still is a heart defect, but when we're talking about an ASD, the cool thing is it could actually be so small that it's asymptomatic. And the beauty of that is it can also actually repair itself and go away on its own. That would be our best case scenario. Some signs and symptoms we may see, so fatigue, dyspnea with feeding with our infants. Anytime you have increased pulmonary blood flow, your heart's having to work harder to pump that blood out into the pulmonary artery to the lungs to get oxygenated. That starts to tax the heart. So it's natural that we could see some fatigue and dyspnea, especially with a baby who has a larger ASD. You may hear your providers specifically mention that they can appreciate a soft systolic murmur at the LSB, which stands for the left sternal border. Again, murmurs, depending on how well you are versed in noting a murmur or how often you've heard that, you may or may not be able to appreciate that on your own, but I guarantee you a lot of your providers may be mentioning that they can hear that murmur at the left sternal border. So treatment-wise, if it's a small enough ASD and there's no other accompanying symptoms, they may in fact actually utilize a watch and wait approach. And what that means is they're going to wait and see if that ASD is small enough that it may potentially close on its own. That is always the best case scenario. If it's not and it remains open, we can go in and do a closure, and we want to do that because as you get older and you're growing and living your life, there's always a potential. One of the complications with an ASD is a paradoxical embolus. We never want to see that happen. So we can also see things like right-sided heart failure develop. We don't want any of that to happen. So if we detect the ASD and we know that has the potential to cause complications, we can go in and do a repair. Now, the beauty of this specific disorder, we can actually do this minimally invasive procedure now in the cath lab to close the ASD. That would be for the atrial septal defect that's small enough for us to actually go in and close. We can utilize patch placement, again, taking that baby into the cath lab, and that's where they'll actually do the procedure. Unfortunately, with any of the cardiac defects, sometimes they don't occur on their own. They may actually occur with other defects. So if we're looking at a baby who has not just an ASD, but some other things going on, we may in fact need to do a thoracotomy and actually go in there, open up the chest, do the whole surgical revision in the OR, depending on the size of the defect, the and any other accompanying defects that may coincide with this ASD. Complications. Your biggest complication that we're trying to prevent from happening is pulmonary hypertension. And when we go back to the drawing in a second, I'll explain to you why that's happening. But you have an additional blood flow. You have the shunting of blood from the left side of the heart to the right side of the heart. That means when that blood hits the right ventricle and gets pumped through to the pulmonary artery, that's extra blood flow that's starting to tax that right side of the heart. So the heart has to pump at a greater force to increase that, to allow for that blood flow. That's an increased amount of blood flow out through the pulmonary artery. So you can definitely see on the right side of the heart this pulmonary hypertension develop. Potentially, they could also develop arrhythmias. And then, as I mentioned, this paradoxical embolus. Because you have an opening between the left atria and the right atria, there's that potential that a clot can actually get into the left atria and make its way out into circulation. That would be the worst case scenario. We never want to see that happen. So that's why once we've identified this patient having an ASD, if we've done the watch and wait and it's not going away, we do want to go in and make sure that we are repairing the defect. At the end of the day, if we did nothing and say the patient, they were fortunate enough that they never experienced this embolus, there's always the potential that they could also develop heart failure. Because when you have this shifting of blood from the left side to the right side, you have extra volume of blood that now the right ventricle is working harder and it has that extra volume that it's pumping out. So we never want to see right-sided heart failure or heart failure in general happening for our patient with an ASD. So now let's travel back to my little picture of the heart. I tried to make it as anatomically correct as possible. Don't judge me on the artwork. What we really want to focus on is the defect and what exactly is happening. So think of a garden hose or pipes in your house. Blood, just like any liquid, blood will always flow from an area of high pressure to low pressure. It's just natural. That's what's going to happen. Pressure is always greater on the left side of your heart. So if you have this opening between the septal wall, between the right atria and the left atria, you're naturally going to have this extra blood volume coming through this opening here because it's going from high pressure to low pressure. So it's going into the right atria. When it gets into the right atria, this blood is already oxygenated because it's in the left atrium. So now it's mixing with deoxygenated blood in the right atrium. So both that oxygenated and deoxygenated blood are mixing in the right ventricle, and both deoxygenated and oxygenated blood are now going to be pumped into the main pulmonary artery. So let me erase this so you can kind of get a better idea. So remember, main pulmonary artery is where in a normal functioning heart, our deoxygenated blood flow is going out to the lungs to get oxygenated and making its way back into the left atria. But now we have some extra blood volume because you have blood from the left atrium mixing with deoxygenated blood in the right atrium, both coming down to this right ventricle and being pumped out to the main pulmonary artery. You may think to yourself, well, I don't understand why that's going to cause pulmonary hypertension because it's just a small amount of blood. Well, while it is a small amount of blood that's being shunted from the left to the right, it is still extra blood volume. So over time, you're going to cause this right ventricle is going to start to be pumping harder because that workload of the heart is increased. We never want to see this increased workload. And we know that that heart's going to have to pump harder and overcome resistance to get that blood to go into the main pulmonary artery, which that is the part that can develop the pulmonary hypertension over time, which we're trying to prevent. So to diagnose this in our patients, if we were suspicious of them having an ASD, ultimately, what does your patient look like? What kind of symptoms? Do we see any of do we hear the murmur present? Do we see the fatigue, the dyspnea with feeding, anything like that? But ultimately, we want to look at an echo that will allow visualization of all the chambers of the heart, the valves, and that the physician will actually be able to see the opening if it is present between the right atria and the left atria. We want to look at a chest x-ray because I told you we can actually tax the right side of the heart if there is this blood being shunted. So if there was that patient who's starting to develop heart failure, we want to look and see what is the size of the heart, what does the heart itself look like, and if we're starting to note any cardiac enlargement, that's always indicative of heart failure. Never a good thing. We don't want to see hypertrophy of the heart muscle. And then, of course, an EKG, because if you remember over here, I mentioned you can, in fact, have arrhythmias develop in a patient who has an ASD. So the good news is, as I mentioned, it's fixable, it's treatable. We'll continue to monitor our patient for complications. But as you're studying, keep reminding yourself, this disorder is, again, it's acyanotic, meaning we will not see cyanosis in the peripheral vasculature, because while we do have oxygenated and deoxygenated blood mixing, both oxygenated and deoxygenated blood are still going out to the main pulmonary artery to get oxygenated and making its way back into the left atrium. Remember, this causes increased pulmonary blood flow that can tax out this right ventricle and cause that pulmonary hypertension of the main pulmonary artery. Hopefully that was a helpful review for you as you're studying ASDs and those disorders which cause increased pulmonary blood flow. Be sure to hit the subscribe button and join the Nurse Lizzie family. Thanks so much for watching.